20. Welcome you all, the attendees and the participants for this session. This session is on the are those symptoms which are very rarely assessed in the palliative care setting. So to discuss, there is Dr. Tines Xerostomia and Dr. Mohesh Menon will be there, who will be speaking about hiccups. So I am Dr. Dipankar Dakwai, palliative care physician from Guwahati, Assam Cancer Foundation, who will be the moderator for this session. The chairpersons for this session will be Dr. Mohana Sundaram and Dr. Tony Bikas Biswas. So Dr. Mohana Sundaram is an anesthesiologist who had turned into a palliative care consultant and who is working in the palliative care, a huge experience in palliative care. He has done his basics in palliative care from the Institute of Pallium in Pain and Palliative Care, Calicut, postgraduate diploma in palliative medicine from Edin Cowan University, Australia, fellowship in successful aging and end-of-life care, Stanford University, USA. He has a postgraduate training in palliative care from National Hospice, Singapore. Then he has multi-professional training at St. Christopher's Hospice, London. Presently, he is the president of Tamil Nadu Palliative Care Society. I welcome you, Dr. Mona Sundaram. And
Thank
Dr.
you very much.
Tony Bikas Biswas is a palliative care consultant. Thank you, sir. A palliative care consultant from CIHSR, Dimapur, Nagaland. He has done his MSc in palliative care from Cardiff University. He has a vast experience of about 10 years. So I welcome you, sir. Now over to Dr. Mohana Sundaram to start the session, please. Thank you.
Good morning. Good morning to everyone. It's nice to speak to each and every one of you. Before beginning our session, I would like to congratulate the organizers and the entire team for arranging the wonderful scientific sessions throughout. Excellent arrangements. Well done, sir. Take our congratulations on all our behalf. You have done a great job. Yes. Coming to today's topics, there are going to be three eminent speakers from different parts. One is going to talk about tenesmus, another one is xerostomia, and exact hiccup. These three are very troublesome for the patients and as well as for the family members. Before we talk, let us ask each and every one of the speakers to come one after the other so that we can have the question hours in the end. Can you invite the first speaker, please? Can we invite this first speaker?
Yes.
Yes.
Hello everyone, my name is Yoshiyuki Kizawa, working and teaching palliative care in Kobe University School of Medicine. It is my great honor to have an opportunity to talk at 29th International Conference of Indian Association of Palliative Care. My talk is about management of rectal tenesmus. I have no conflict of interest to disclose. Firstly, I'd like to talk about my situation where I work and where I live. I live and work in Kobe. It's a central part of Japan near Kyoto and Osaka. It's very beautiful city and famous for gourmet, especially for beef, Kobe beef. So now I work and teach and work in palliative care in Kobe University Hospital. We have 900 beds and we have a lot of cancer patients in the hospital. and it was designated as government-designated cancer hospitals in Japan. It's our palliative care team. It was established in 2006. Now we served for about 500 patients every year. We have 3 faculties and 2 psych-oncologists and 2 clinical nurse specialists. And next, I'd like to talk about end-of-life care and palliative care in Japan. We have 1.3 million deaths in Japan in 2017, and we are in aging society, so it increased to 1.6 million by 2040. The leading cause of death is cancer, about 30%, and also 70% of death was occurred in the hospital. This slide summarizes our national health insurance system in a single sheet. It was fully covered by public insurance. Patient pays 30% of all medical costs. And we also have a cap of monthly payment, about $1,000 US dollars per month. Free access is guaranteed, so it means every patient can consult with every hospital or clinic in the country, and no GP systems. This slide shows development and history of palliative care in Japan briefly. The first hospice palliative care service was started at 1980s in Seirei Mikatabara Hospital, and insurance coverage was started in 1990. And other epoch-making thing is occurred in 2007, that the Cancer Control Act. This was a very epoch-making thing for us. We have 434 designated cancer hospitals all over Japan. These must have specialized palliative care teams and hold education for primary palliative care. This is Cancer Control Act. It was started 2007. This slide shows the current status of specialist palliative care in Japan. We have 455 hospice palliative care units in Japan, and this covered 16% of cancer deaths. And we have over 1,000 palliative care teams in Japan. This covered 28% of cancer deaths in Japan. Overall, 40% of all dying cancer patients received care from palliative care specialists. Now let's move on to tenesmus, talking about the tenesmus. Firstly, I'd like to talk about definition, clinical impact, and epidemiology of the rectal tenesmus. This slide shows the definition. It was defined as painful sensation of incomplete evacuation of the bowel, resulting in the sensation of needing to defecate many times daily. It is often associated with rectal pain. The pathophysiology is complex and not fully understood. It is a very distressing symptom. On a personal note, my uncle committed suicide from this syndrome and passed away 10 years ago. It was so sad. He also had a depression. This slide shows prevalence of rectal tenesmus, 14% of rectal cancer patients, and also 0.7% of hospice patients. We clarify the prevalence and associated factors of orphan symptoms, including tenesmus, in 2017. It's a multi-center observational study among hospice patients. The prevalence of tenesmus is 0.7% in hospice admission. So next is current clinical evidence of the management of tenesmus. We can find two systematic reviews. One is conducted in King's College London, and another one is in Canada, British Columbia, and published in 2017 and 2019. All articles that was met inclusion criteria of these two systematic reviews were case series and case reports. A variety of treatments were found in both systematic reviews, but overall evidence was limited due to poor study quality. The possible treatment is as follows. As pharmacological intervention, so opioids including morphine, oxycodone, and methadone, and also fentanyl, and non-steroidal anti-inflammatory drugs, and calcium channel blocker, for example, nifedipine and diltiazem, and local anesthetics. That was subcutaneous injection, continuous subcutaneous injection, and also ketamine and gabapentinoid. So for non-pharmacological intervention, many reports exist, like sympathetic neurolysis, for example, lumbar sympathectomy, superior hypogastric block, and ganglion implant block, and also intrathecal neurolysis and epidural neurolysis. We can't leave patients in pain just because there is no established treatment and evidence. I will talk about how we should manage these problematic symptoms and how it is practiced in Japan. So firstly, we should consider treatment of underlying condition in the first place. So we are considering about the indication of surgery and colostomy, and also indication for radiotherapy and chemotherapy. Since constipation and stool impaction due to colonic stricture and opioid side effects are important cause of tenesmus, control of constipation is very important issue. So we should consider opioid rotation to methadone or fentanyl, which are relatively less likely to cause constipation, should be considered. Fasting and intravenous hyperalimentation should also be considered. If stool impaction does not improve, colostomy may be indicated. So in the case of rectal cancer, consider radiotherapy and chemotherapy after construction of a colostomy is very important. It's very important thing. This slide shows the pharmacological and non-pharmacological management of tenesmus. It is very important to increase the dose of opioids until side effects such as drowsiness become clinically problematic. And as a general rule, prescribe NSAIDs in addition to opioid is important because there are some inflammation with rectal cancer. And consider using methadone. It's less likely to get side effect of constipation. If tenesmus doesn't improve with opioids, try adding gabapentinoids. I always start with gabapentin 200 to 400 mg daily, or nifedipine 10 to 20 mg twice daily. And I always consult with an anesthesiologist if tenesmus doesn't improve with opioids, and consider sympathetic block and also intrathecal analgesia or neurolysis. And next step, we don't have enough research evidence at this area. And tenesmus is a rare condition and requires a large number of cases to conduct an prospective trial. International multicenter studies are preferable as sufficient numbers of cases may not be available at the national level. So it is better to first firmly determine the diagnostic criteria for tenesmus and then conduct a prospective observational study to see the effect of real-world treatment. So we are thinking to use Asia Pacific Hospice Palliative Care Network as an international research platform. Now I'm chairing the research committee of IAPCON, so why don't you stop leaving your clinical questions unanswered? Let's talk together, conduct clinical research, and return the result to the patient in front of us. Thank you very much for listening.
Sir, you are muted, sir. Sir, you are
unmute
muted.
yourself, sir.
You have to unmute yourself, sir.
So for the excellent and elaborate talk on tenesmus, your topic really distressing for the patient as well as for the family members. Spending more time inside the toilet, not knowing what to do and how to get rid of this is the biggest problem. It not only implicates physical problems like pain and other symptoms, not only that one, it depresses the individual and put into so much of psychological and social problems. Many a time these patients used to spend many time inside the lavatory because they are afraid to come out because of the pain. And such a thing is highly elaborated under the cause and the pharmacological, non-pharmacological methods are clearly discussed by the speaker. Anyhow, we will keep the questions and other suggestions in the end. Let us welcome the next speaker to speak about. Thank you.
Hello, everyone. My name's Gowri Agarwal. I'm delivering this talk from Sydney, and I am very excited to be here to present my talk on xerostomia. The first thing I'd like to do is thank the Indian Association of Palliative Care for inviting me, and Dr. Anjum in particular. I so wish to have been in Jaipur with you all, but times currently with the COVID pandemic makes everything needing to be online platforms. So I hope you're enjoying the conference. Xerostomia is something that is one of the orphan symptoms that is often under-recognised, under-reported. It is a subjective sensation of dry mouth, and it could either be from a true malfunction of the salivary glands, but as you and I know, most of our patients, it's a subjective impression of dry mouth, and it could be normal or suboptimal secretory gland function. The major problem is it often goes unrecognised. We probably have it in the back of our minds that most of our patients have dry mouth and they're not talking about it. There's a significant impact for the patient, and it impacts them not only as a physical symptom, but impacts them on a global quality of life, socially is unacceptable to them, and sometimes can really impact negatively on their psychosocial well-being. The prevalence of xerostomia is actually very high. Up to 70 to 78% of patients in their last weeks of life, no matter the diagnosis, whether it's cancer or non-cancer palliative care, most of these people have a degree of dry mouth. There was an integrated systematic review performed and published in the palliative care population. And what they found was a cluster of symptoms, the most common oral symptoms, and xerostomia was certainly top of that list, with oral candidiasis, dysphagia, mucositis, orofacial pain, taste changes, and ulceration as well. There appears to be a lack of healthcare providers' knowledge about taking a good history around this, and also what we may be able to do to improve the symptoms. This particular systematic review suggested that having dental professional involvement in palliative care patients and improving that knowledge and understanding was important, and to not underestimate that we need to educate our patients to prioritise xerostomia as something important and to improve their compliance. Associated with this is the impact on sleep. Many of our patients wake up in the morning telling us that they've had a dry, uncomfortable mouth that's preventing them to sleep at night. Their speech is abnormal. They're constantly reaching for a glass of water or have very sticky, dry mouth and are unable to converse, which is exacerbated by the fact that they're starting to deteriorate generally, and general lethargy and weakness confounds it. There are issues around taste, chewing, often associated dysphagia and swallowing, and definitely there can be a social embarrassment, a reduced food intake, and we know at the end of life there is a reduced appetite, and anorexia becomes an issue, and chronic oral discomfort, which can occur. When we take the history, I think the approach is to be proactive in asking our patients, do you wake up through the night, or do you wake up first thing in the morning with significant dryness in the mouth? Does it prevent you from conversing, swallowing food? Is the dry mouth only there pre Meals, is it hard to swallow? Do you always have water next to your bed? Are you constantly applying something in your mouth or drinking fluids or sucking on mint or other candies or sweet preparations or chewing gum? What are the things that you do to help alleviate the dryness? And are you constantly wanting to moisten your mouth? So keeping that sort of history that we take the pains to look at in other symptoms such as pain and breathlessness, we need to not forget these orphan symptoms such as xerostomia. When we look at the recognition of cause, we understand that it's not just the traditional oral candidiasis, which there is a propensity or prevalence of that in our patients in palliative care, and certainly patients in cancer receiving steroids or other anti-cancer treatments, but other causes such as hypercalcemia, vitamin deficiency such as zinc deficiency, B6 deficiency, even calcium deficiency, anxiety, depression with hyperventilation, hypothyroidism, commonly in our patients, diabetes. We've commonly seen it as a spectrum in autoimmune conditions such as Sjogren syndrome. And so as these patients with autoimmune diseases develop sort of end of life, this can be compounded. As I said, other infections apart from oral candida or thrush, head and neck cancers, which is, there's a high prevalence of that in India, and also the fact that smoking and betel nut chewing may exacerbate that xerostomia. Poor dental hygiene, smoking, and of course treatments, not only radiotherapy, which is the biggest perpetrator of this, but also sometimes chemotherapy can do that as well. Medications, a long list of it. And in our palliative care population, we know that we do rely on opioids and also other anticholinergic medications, including the anti-neuropathic drugs that we use, including gabapentin, pregabalin, but also other drugs such as haloperidol, buscopan. All of those sort of things will exacerbate dry mouth, including amitriptyline, which we might use as an anti-neuropathic agent. So explaining that, communicating and educating our patients, and then providing some symptomatic relief is very important if you're not able to reduce that medication load or change the medications or stop it altogether. When we look at head and neck, we know that radiotherapy causes reduced saliva and very sticky saliva. And few patients usually have that xerostomia at the start of therapy, but almost up to 100% during radiotherapy, regardless of whether they have intense or prolonged radiotherapy. Acute, subacute, and late side effects. So some patients are reporting it even 2 years after completing their radiotherapy. And there are significant associated symptoms and other aspects which impact negatively on their end-of-life quality assessments, as demonstrated in many studies in the EORTC, quality of life, head and neck for this example. And most of the research have looked at prevention by dose modification, looking at reduction in dose intensity, the field of radiotherapy, or using radioprotectants, which I will allude to shortly. So the first thing is to treat or reverse the cause if possible. So removing some of those medications that I said, treating infections, etc., but making sure that we really have a positive strategy towards good oral hygiene, denture management, avoidance of dry, acidic and salty foods, elimination of stimulants that cause or exacerbate xerostomia, such as tobacco and alcohol, and prevention of candidiasis. And it's interesting, if you look at the research and studies, a single dose of fluconazole at 150 milligrams have been shown to be equally effective as a more protracted, say 50 milligrams BD or 3 times a day of fluconazole over a longer period of time, or 100 milligrams twice a day for 5 days. So most of the management for xerostomia becomes asymptomatic, and it's usually about replacement with salivary substitutes or stimulation with oral and peripheral agents. They come in a multitude of ways: presentations, gels, aerosols, lozenges, oral rinses, chewing gum. It's trying to induce saliva production. But simple strategies such as fresh pineapple pieces, frozen lemon slices, some even have used frozen tonic water. But the idea is to make sure, apart from oral hygiene, lubricate the lips, lubricate the mucosa, even on an hourly basis. In India, being a tropical zone, you know, it may not be as dry as areas such as in Australia. However, it's sometimes independent of the weather. So keeping the lips and mucosa lubricated, and regular mouth washes, and I'll talk about sodium bicarbonate washes. So as I said, symptomatic, saliva substitutes, oral lubricants, salivary stimulants, and pilocarpine is one drug that you can utilize because it has a positive parasympathetic activity which induces salivary stimulation. Prevention of oral diseases that impact on the salivary gland is helpful, but many articles at the end of the day show that frequent sips of water seems to be just as effective as all of these other agents, which can be very costly to our patients and may not be easily accessible in the community. Main problem is human saliva is the best product. And it's the best product because it contains digestive elements and enzymes, but bactericidal enzymes, which is natural occurring proteins within the saliva. And this is very difficult to replicate in artificial products. A simple thing that I often tell my patients, definitely those that are having anti-cancer treatment, immunotherapy, and starting to have xerostomia, is washing their mouth, rinsing with a concoction of sodium bicarbonate powder, simple sodium bicarbonate, half a teaspoon dissolved in a glass of warm water, and washing the mouth out 3 times, 4 times every 2 hours. And some people find that helpful. Herbal rinses, and I am sure in India, Ayurvedic medicine treatments might be a plausible alternative that's more readily available in our community. Recent studies have shown perhaps acupuncture in some patient populations, and I've given you some authors that have written about this, and responses as early as 8 treatments with reduction of xerostomia and increased salivary production has been shown. Other drugs that have been used more in radiotherapy is amifostine. It's a broad cytoprotective effect on normal tissues by producing free radical scavengers and hydrogen ions, which assist in molecular repair. The side effects are hypertension and vomiting. Other things available are pilocarpine drops, which we use as a parasympathetic agent, as an eye drop, and using 4% of that dropped twice a day, 3 times a day, can increase saliva production. And for some patients where you've tried all of those other oral-based agents, this might be an option. In Sjogren's disease, they have used muscarinic receptor activists, and I'm not very familiar with this product. One thing I wanted to tell you was we actually did a pilot study in our 20-bedded palliative care unit just a couple of years ago, and we're yet to fully publish, but we presented the data at a number of lectures and conferences. And what this pilot study was the utilization of 3 different products, which I've mentioned there, including one that we tend to use commonly now, which is the second product, Biotine Oral Balance Gel, which is a water-soluble saliva substitute. And I've written there and listed the enzymes that are part of that, and then comparing that to sodium bicarb swabs. And what we actually found was there were 3 different mouth products, as I described, but they were not statistically different. When we looked at patient scores for xerostomia, as well as looking at quality of life index, they weren't any better one over the other. There was no superiority. All groups showed worsening of xerostomia symptoms over the 7-day trial period. And don't forget, this is patients in a palliative care unit with complex other symptomatology. And the limitation of our pilot study was a short duration of study, and therefore there was a deterioration that we saw, and a very small cohort of only 26 subjects, 18 completing the 7-day trial. But what we actually found was improving not only patients, but staff awareness of xerostomia, and now addressing other aspects to care, oral hygiene, lubrication, and all of that has become part and parcel of the way we manage it in our unit. In the terminal phase, please remember that the ongoing xerostomia may not be, and is usually not a reflection of dehydration. It is because of the medications, the opioids, the anticholinergic drugs, the mouth breathing, the application of oxygen perhaps, and it will not resolve with the implementation of parenteral fluids, either IV or subcutaneous artificial hydration. So good communication, explaining this to the patient, but also the patient's families, and also helping staff understanding this is very important. Getting our families to help with mouth care on the hour, every hour, becomes really, really important. So in summary, evidence is there is a paucity of quantitative and qualitative research in xerostomia. There's an underreporting, under-recognition, and probably not enough exploration of the associated features and causes for that xerostomia. There's no large-scale trials or protocols available around the world. And it's, I think, determined by what is available in your country, what's available in India, in your institution, what's available in mine. And that's what we as clinicians will prescribe. But the huge aspect is the cost factor. What's available in the community, in our rural settings? How can we easily assist families to help the patient? Education is so important, isn't it? For the patient to improve compliance and reporting to us, but staff in how meticulous we need to be with mouth care. So thank you all very, very much. And I hope you continue to enjoy the conference, and I look forward to some questions shortly. Thank you.
Sir, please unmute yourself, sir. Right.
Thank you very much, Dr. Maurya Agrawal, for the wonderful talk about xerostomia, the dry mouth. Often underreported, yes, it is. but not even recognized by many. Almost all patients suffering from after the radiotherapy with one stage or other have some sort of xerostomia. Though the pharmacological approach to treat all the causes are not seems to be quite useful. Getting into non-pharmacological methods like lime pickle, pineapple chunks, ice frozen, etc., etc., all those things definitely play a major role, especially in developing countries where they are not afford to buy artificial saliva. Above all, there's need to be a good communication is very, very important and vital, as told by the speaker. Education to the staff to recognize the symptom is much more important, as that also she has expressed very well. Let us wait for others to ask some more questions while we will invite the next speaker to talk about the next topic.
Greetings everyone. Welcome to today's session on orphan symptoms in palliative care. The orphan symptom that I will be speaking on is hiccups. The European Society for Medical Oncology describes orphan symptoms as those which are not regularly assessed in clinical practice, and consequently they are studied little and they are not properly treated. This is true with some of the orphan symptoms that we have described and seen here. However, in palliative care, we notice that when palliative care delivery is not optimal due to multiple factors, and when mainstream symptoms like pain and dyspnea are not addressed well enough in medicine, orphan symptoms also take a backseat like their counterparts. And sessions like these play an important role in sensitization and bringing attention to these topics so that we can treat each and every symptom that the patient may experience and address as many points as possible, thus minimizing distress and improving our patients' quality of life. I shall discuss a basic introduction to hiccups and understanding a cause of hiccups, their treatment, and a few references. We know that hiccups are caused by a spasmodic movement of the diaphragm in between respiratory episodes. This leads to a closure of the glottis, which leads to the characteristic hic sound. This article by Steger et al. Has excellent material and resources on hiccups. In the previous video that was shown in the article, one could clearly discern the hic sound that is caused by hiccups or singultus as they are known. We know them as benign symptoms, but are they relevant enough in palliative care? The classification of hiccups from an acute attack, which is less than 48 hours, to persistent hiccups greater than 2 days, intractable hiccups lasting more than 1 month, has been described as early as 1991 in an article. One of the longest durations of hiccups has been reported to be around 67 years, which supposedly went away with a prayer to the patron saint of lost causes. Coming back to our discussion, let us look at our patients who are assessed with the revised Edmonton Symptom Assessment Scale and understand how hiccups may adversely affect all the other symptoms which are noticed. For example, patients who have incident pain may have a worsening because of the sudden movement caused by the hiccups, like bone metastases, spine metastases, visceral pathology, intercostal pains can worsen. Appetite reduces, the patient is constantly burning energy, there is fatigue, there is drowsiness because of daytime somnolence, poor sleep, reduced oral intake, affecting nutritional status, affecting energy, breathlessness because of fatigue, tiredness, in addition to the constant movement of the diaphragm. An adverse effect on the mood because the symptoms not getting better and probably associated with disease progression. So there is a multi-dimensional impact of this multifactorial pathology. Causes. There is a hiccup center in the spinal cord in the medulla oblongata near the respiratory center, which stimulates via the vagus and the phrenic nerves, which receives inputs via somatic neural structures as well, and via sympathetic and autonomic ganglia, which interplay leading to a contraction of the diaphragm. The central causes could be neurological, which is seen in neurology, in palliative care in neurology it is seen. We see that peripherally in gastrointestinal issues like distension and visceral pathology. We could see it in non-gastrointestinal causes with structures that involve the mediastinum, irritate the phrenic nerve. We could see it with drugs. One of the more prominent associations is with steroids, and some of these drugs like opioids and steroids and chemotherapy agents are used. In a study of 1,896 patients, Nishijima et al. Reported an association with digestive tract obstruction, diabetes with any of the three major complications, male gender, and renal failure. Let us look at the treatment of hiccups. The first thing is to listen to the patients, understand their history, and some of the patients may have devised their own measures that are effective in the treatment of hiccups. There's no harm in following that. Non-pharmacological measures work by interrupting the respiratory cycle, irritating the nasopharynx, preventing the irritation of the diaphragm, and via acupuncture and complementary and alternative modalities. We can lean on some of these, although there is no evidence for the impact that they can have in the treatment of hiccups. So the first line is to also always try non-pharmacological measures in conjunction with pharmacological measures and others while we are looking at the treatment of the underlying cause. Recommendations which were made in a supportive and palliative care journal recently veered towards the use of midazolam if the patient were in the last days of life. Again, in the study of the prevalence of hiccups, it was noticed that the incidence and the prevalence of hiccups increases towards end of life, towards the last days of life. It is very high, and as it keeps increasing if it is already present. The use of a proton pump inhibitor has been recommended if no overt cause has been detected. We can try and cut down on the drugs like opioids, benzodiazepines, dexamethasone while balancing patient condition. Correcting underlying toxic and metabolic factors plays a role. If we are to look at an algorithm, a simple algorithm that has been described is for the peripheral causes. If we suspect gastric involvement like distension and so on, or visceral pathology, we can go with metoclopramide and proton pump inhibitor as first line, baclofen and gabapentin as second line, chlorpromazine and the others as third line. If we suspect non-gastric causes like thoracic causes, we could go with metoclopramide first line, baclofen and gabapentin second line, chlorpromazine as the others. Baclofen and gabapentin work through neurological measures by the GABA channels and through their impact on neuronal mechanisms involved in hiccups. Since baclofen and gabapentin act via neuronal channels, they are preferred in hiccups when the cause is presumably central, where they have first and second line respectively. If you look at the recommendations made by the European Society for Medical Oncology, baclofen, gabapentin, chlorpromazine, haloperidol, steroid rotation, midazolam, and acupuncture are described. Of these, steroid rotation is the highest level of evidence. In this slide, the highlighted text reflects my experience with managing patients who have hiccups. I have seen patients with solid tumors with hiccups, a lesser number of patients with hematological malignancies with hiccups, and have seen a few patients with renal factors and with central causes who have been referred for the management of hiccups which have not been amenable to treatment. We have used baclofen and gabapentin and have had good results. We've used chlorpromazine, and in one patient I have used prochlorperazine for the relief of symptoms. Literature also describes the role of phrenic nerve injections, which can be done simply using ultrasound. However, I do not have any experience with interventional management for hiccups, although they are theoretically doable. With this, I would like to end my talk. These are a few references for the topic. Having said that, a lot of work can be done in this topic if more literature and more research is done from the stalwarts in palliative care and from all those who are working in palliative care. Best wishes to everyone. Take care, stay safe, and thank you to the organizers once again for giving me this platform to interact.
Thank you very much, Dr. Thank you very much, Dr. Mahesh Master, for the nice explanation about hiccup. Hiccup is a symptom which hardly been expressed by the patients, especially when they are okay. But whenever they are going into the almost the end of the stage, or when the metastasis occurs in the different areas, especially in the thoracic areas, as explained by the speaker, definitely produces a huge upset to the patient. The spasmodic contractions often stimulates a lot of changes, not only that one, physical, psychological also. As far as the symptoms or treatment options, there are many options which are explained, and many of them are this one. But chlorpromazine seems to be better and cheaper for the developing countries, especially metoclopropamide and other, with even promethazine helps to a great extent. But we leave it at this time, that our question and answers, and we'll ask the audience to ask the questions to the speakers, please.
There is a question for Dr. Gauri. Is Dr. Gauri there?
Yes, I'm here.
Yes, thank you. There is a question from Dr. Kale. He asked how to reduce post-radiation fibrosis.
So I'm assuming the question is about head and neck radiotherapy causing xerostomia. So most of the evidence has been very much targeted at the dose intensity and the fractionation of radiotherapy. And so if you're able to change those parameters, sometimes you can have a protective phenomena. So fibrosis, unfortunately, as we know with radiotherapy, does have subacute and long-term consequences. So I think the main thing is during radiotherapy, it's not the prevention of fibrosis, but the regular oral hygiene, keeping the area moistened, etc., is very important. And sometimes just using all of the other lubricating factors that I talked about. Most important thing is often steroids are utilised alongside radiotherapy, and so therefore you want to make sure that you have a developed oral thrush. Cytoprotective agents are now being utilised, but the whole issue is one of cost whether it's available in your institutions. These are scavenger radicals to try and improve the consequences of those radiotherapy, but I don't think they're freely available and they're not used in all services. So hopefully I've answered that question.
Yeah, I think so. Yeah, thank you so much. There's another question for
Just
you.
to add one thing, as she expressed that oral hygiene plays a major role in the prevention as well as a part of treatment to xerostomia. There is a small suggestion from our side that I am using it for the past almost 10 years at our palliative care center. How to make a oral cleansing solution in the home preparation. The formula is simple. Take 1 liter of water, add 1 handful of table salt, add 5 ml of betadine nitrogen solution and 3 ml of hydrogen peroxide. Add metrogyl tablets crushed 1 or 2 together with 1 or 2 peppermints. If you form a mix, that will come about nearly about 1 liter. The patients can do a mouthwash more than 5 to 6 times a day and keep the bottle for 2 to 3 days. They can again make the preparation fresh. In this way, they save a huge volume of money and prevents them from buying artificial mouthwash or commercial mouthwashes available in the market at a higher cost. This is we have been doing, we have faced a very good results, and this is just to add something to what Dr. Gauri has said. Excellent answer, madam. Thank you very much.
So, Dr. Gauri, there's another question for you about human saliva, as you have mentioned that it's the best. So, what are the implementations? Like, how is it available? What's the cost? And is it socially acceptable to everyone?
That's a very tricky one. I think, you know, pharmaceutical organizations and dental organizations have been trying very hard to replicate the salivary gland. I think sharing saliva in the days of COVID will pose a significant issue, I think, at present. So it really goes down to a synthetic alternative. And so I really can't comment on the preparations available in different parts of India and different parts of Asia. But in Australia, we're tending not to use, it's just artificial saliva. And some patients will prefer a certain type because of the smell, the taste, whether it's helpful for them. And others just hate it altogether. And as I said, you know, simple things like bicarbonate mixed in water because it actually provides some oxygenation in the mouth. Those sort of measures are helpful.
Thank you so much. Another question coming for you, it's about using Coca-Cola for rinsing mouth. So what do you say about that?
I think Coca-Cola, I hope whoever asked that question doesn't have shares in Coca-Cola, but I think the problem with a lot of the sweet products that our patients use causes poor dentition. And that's why having dental practices within palliative care services is very helpful, not just for education. So when people are constantly drinking sweet products, they're worsening their dentition, they're causing problems. We know that Coca-Cola has so much of proactive stain removers. So imagine what it's doing if you're constantly drinking. So I think safe products without a high, it's not the sugar content necessarily, although diabetes is such a high prevalence in Asia and certainly in the Indian subcontinent as well. So we need to be very careful with those sort of products.
Thank you,
Dr.
so
Thank you very much for the good answer. As we are coming nearly to the time and it is going to be a time almost, the organizers are just cautioning us not to exceed the time. Thank you very much for all the participants. And any more questions, if the organizers make arrangements to share the email IDs of the speakers so that individuals, if they have any specific questions to the concerned speaker, they can straight right to them and get the answer and explanation much more better. So thank you very much, and we again congratulate the organizing team for excellently arranging that show and the conference is going on, and we wish her all the best for the remaining period of our conference. Thank you very much. Thank you all.
Thank you.
Thank you. Thank you very much.
So much. Thank you. Bye.